Okay, so let's just picture the scene. It's exam day. You're standing outside the ward for the FCPS Part 2. The air conditioning is humming, but, you're sweating.
Hmm.
You're about to walk into the long case. You know the drill. 40 minutes to take a history, do an exam, and then present a management plan that proves you're safe.
It is the ultimate pressure cooker.
Yeah.
And then you walk in, you greet the patient, you ask that first question,
Yeah.
and they say, "Doctor, I have joint pain."
And on the surface, that sounds manageable. I mean, we've all had a sore knee. But in the exam, joint pain is this massive, chaotic battlefield. It could be a gym injury, or it could be a catastrophic infection that destroys the joint in, 24 hours?
Exactly. The differential is just incredibly broad. If you just go in there relying on intuition, you will get lost. You have to have a framework, a system that just filters all that noise.
And that is exactly what we're doing today. We're taking a deep dive into the long case format guide for the FCPS Part 2, specifically looking at arthralgia and arthritis. We are going to turn that vague symptom into a precise logical checklist.
We are. We're going to cover the critical pivots, how to tell inflammation from simple wear and tear.
Right.
And we'll break down a safety net mnemonic, PIM HUG, FOSS-TVF, which makes sure you never miss a hidden clue.
Okay, let's start right at the beginning then. The source material draws a hard line immediately. Before we even talk about diseases, we have to talk about definitions. So, arthralgia versus arthritis.
Yes.
Patients use them interchangeably, but in the exam, mixing those up is a fatal error, isn't it?
It absolutely is. I mean, if you tell the examiner the patient has arthritis, but you haven't established the clinical signs, you've already lost credibility. Arthralgia is subjective. It's the patient just telling you, "My joint hurts." It's a symptom.
Right, just the sensation of pain. But arthritis is.
Arthritis is a clinical finding. It implies objective inflammation. You're not just listing anymore. You are looking for evidence of a fire. You need to see swelling, feel warmth, find tenderness, or demonstrate a reduced range of movement.
So practically, when I'm taking the history, I can't just accept pain. I have to dig for those signs.
Yeah. You have to ask, is the joint swollen? Is it red? Does it feel hot to the touch? Because if those signs are there, the whole diagnostic pathway changes. You're now dealing with an inflammatory process.
Okay, so we've established fire versus just pain. Now, the introduction. The guide mentions the basics, name, age, and so on. But it has a specific instruction in the show empathy section. It suggests saying, this must be difficult for you.
Yes, I will try my best to find the cause and guide you properly.
Is that just bedside manner?
It's more than that. I mean, yes, you're being graded on communication, but more importantly, patients with chronic joint pain, like in rheumatoid arthritis, they've often been suffering for years. Acknowledging that builds instant rapport. It signals, I'm on your team.
And they're more likely to give you the details you need.
Exactly. So once that rapport is built, we get to the presenting complaints. The guide highlights 4 pillars: joint pain, swelling, morning stiffness, and reduced movement. Let's start with duration. It splits this into acute and chronic. Where's the line?
The cutoff is 6 weeks. That's a pretty standard metric in rheumatology. Anything over 6 weeks, we call it chronic.
And why 6 weeks? Is that arbitrary?
Not really. Most viral arthritides, so joint pain from a virus, they'll resolve within 6 weeks. Same for most minor injuries. If the inflammation is still there after 6 weeks, you're looking at something more pathological, RA, OA, or a connective tissue disease.
And if it's under 6 weeks?
Then it's acute. And your focus shifts to immediate threats. Is it gout? Is it septic arthritis? And the onset matters too. Sudden, like waking up screaming in pain, that points to crystals or infection. Gradual is more the slow burn of RA or OA.
Okay, so we've got the timeline. Now for the part I find fascinating, the math of the diagnosis. The guide breaks it down by the number of joints.
It's the pattern recognition filter. We put patients into 3 buckets. First, monoarticular, just one joint.
So a patient points to a single knee and says, it's just this one. What's going through your head?
Danger. Monoarticular arthritis is septic arthritis until you prove it's not. You have to rule out infection because that joint can be destroyed in days.
So septic is the big red flag.
It's the biggest. If it's not septic, then you think gout or trauma. But you rule out septic first.
Okay, bucket number 2, oligoarticular.
Right. 2 to 4 joints. This is a very specific neighborhood. When you see that pattern, especially if it's asymmetrical, say a left knee and a right ankle, you should immediately think of the spondyloarthritis family.
So things like reactive arthritis or psoriatic arthritis.
Exactly. And finally, the crowded room, polyarticular, more than 4 joints.
And this is where the heavy hitters live.
This is RA, lupus, viral arthritis, or, widespread osteoarthritis.
So just by counting to 5, you've already narrowed it down hugely. But the guide says we need to get even more granular. We have to look at the geography, the specific site. This is where the hand becomes a map, right?
The hand is maybe the most important diagnostic tool in rheumatology. The specific knuckles involved can tell you the diagnosis. For example, you look at the MCP joints, the big knuckles, and the PIPs, the middle knuckles.
And if those are swollen and tender?
That is the classic signature of rheumatoid arthritis, or SLE. RA just loves the small joints of the hands.
But what if the pain is further down, at the fingertips, the DIP joints?
That is a crucial fork in the road. Rheumatoid arthritis almost never affects the DIP joints. If you see inflammation at the fingertips, you are looking at either osteoarthritis or psoriatic arthritis.
Wow. So that one little detail can basically rule out RA.
Precisely. Psoriatic arthritis loves the DIPs. RA hates them. It's a pattern that rarely lies.
Okay, what about the bigger joints, the axial skeleton?
If the patient complains about back pain or buttock pain, specifically the SI joints, you pivot to ankylosing spondylitis. RA typically spares the lower back.
And the final piece of this map is symmetry. Is it a mirror image?
Yes. Symmetrical disease, right wrist and left wrist, right knee and left knee, that suggests a systemic bloodstream issue. The immune system is attacking that tissue type everywhere. That screams RA and SLE.
And asymmetrical, just random hits.
That points you back to the spondyloarthritis family, gout or reactive arthritis.
Okay, so we've mapped the joints. Now we come to what I think is the most critical pivot in the whole thing. Differentiating inflammatory versus degenerative. Is this an immune system attack like RA? Or is it mechanical wear and tear like OA?
This is where you pass or fail the case, and you can't rely on an X-ray here. You have to rely on the history. The key question is about morning stiffness.
Right, but we all feel stiff in the morning. So how do you tell the difference between getting old stiff and disease stiff?
It's all about duration. You ask, how long does it take for you to loosen up in the morning? And the magic number is around 30 minutes to an hour.
If it's less than 30 minutes.
That's mechanical. That's osteoarthritis. You wake up, you're a bit creaky, you walk to the kitchen, make a coffee, and you're fine.
But if it's longer than that?
If the patient says, "Doctor, it takes me 2 hours to get moving," that is inflammatory. We call it the gel phenomenon. During the night, when you're still, all the inflammatory proteins and fluids in the joint, they settle and thicken. Like cold engine oil, it turns into a gel.
That's a great visual.
And it takes a lot of time and movement to thaw that gel out and get the fluid moving again. That's why the stiffness lasts so long in RA.
Which leads right to the next point, activity versus rest.
Exactly. Because of that gel, patients with inflammatory arthritis, like RA, they feel better with activity. They want to move. Movement thins out the fluid.
And the osteoarthritis patient?
They have a mechanical problem, worn out cartilage. So for them, movement is friction, and friction is pain. So in OA, activity makes it worse, and rest makes it better.
It's a perfect inversion. RA patients walk it off, OA patients sit it out.
Correct. And that one distinction directs your entire management plan.
The guide also mentions the pattern of movement over time. Intermittent, migratory, and progressive. Migratory always sounds so strange.
It is a strange phenomenon. In things like rheumatic fever, the inflammation literally moves. It will hit the left knee, stay for a few days, resolve completely, and then suddenly attack the right elbow. It migrates.
Like a traveling circus of inflammation.
A very painful circus.
Yeah.
Whereas gout is intermittent. You have flares and then periods of complete normalcy. And RA is progressive. It's additive, getting worse, and involving more joints over time if you don't treat it.
Okay, let's zoom out a bit. We've been looking at the joints under a microscope. But the guide really emphasizes associated features and extra-articular manifestations. This is where we have to look at the whole person.
Right, this is the detective work. Autoimmune diseases are systemic. The joint pain might be the loudest symptom, but the clues are often written all over the body. You start with constitutional symptoms: fever, weight loss, fatigue.
Which points to a systemic fire RA, SLE, and infection.
Exactly. OA doesn't give you a fever. Then you do the glance diagnosis. Look at the skin. Do you see psoriatic plaques? Do you see the malar rash, that butterfly rash on the cheeks that just screams SLE?
And what about the eyes? The guide mentions looking for redness.
A red, painful eye uveitis is a really strong connector to ankylosing spondylitis. If you have a patient with back pain and a red eye, you've probably got your diagnosis. Dry eyes and a dry mouth points you towards Sjogren's syndrome.
And the mouth itself.
Oral ulcers. Painless or painful ulcers in the mouth are classic for SLE or Behçet's disease. And don't forget to ask about hair alopecia, or hair loss, is a major feature of lupus.
It's incredible how connected it all is. The guide also mentions functional impact, asking about combing hair, gripping a cup. Is that just to assess disability?
It does that, yes, but it also helps you localize the problem. If a patient can't comb their hair, that's a shoulder limitation. If they can't button a shirt, that's fine motor skills in the fingers, which points you back to RA. It grounds the theory in their reality.
Okay, before we get to the safety net, we have to talk red flags.
Yeah.
We touched on septic arthritis, but let's be crystal clear. What's the presentation we absolutely cannot miss?
A single hot, swollen joint with a fever.
Huh.
If you see that, you stop. You don't refer to an outpatient clinic. You admit them. You aspirate that joint immediately. It's a medical emergency.
Any others?
Yeah, rapid development of a deformity or severe back pain with neurological deficits like numbness in the legs, those require immediate escalation.
Okay, so we've done the history, characterized the joint, figured out the nature, looked for systemic clues. But in the stress of an exam, it is so easy to forget one crucial question.
Like you forgot to ask about travel or family history.
And that's where the mnemonic comes in. The guide provides a code. PAMHUG, FOSS-TVF.
It sounds like a secret agent's password. It's a mouthful.
It is. It really is. But let's break it down into clusters. It's actually not so bad. Let's start with the medical history cluster. PAAA. P for past history. A for allergy. M for medications. This is vital. Is the patient on diuretics? That can cause gout. And H for hospitalization.
Simple enough. Now the screening cluster. U and G.
U is urogenital or obstetric history.
Hey.
You ask because recurrent miscarriages are a feature of SLE. Urethral discharge can point to reactive arthritis. And G is general screen diabetes, hypertension, TB, thyroid.
Why do we care about diabetes in a joint pain case?
2 reasons. 1, diabetes is a risk factor for septic arthritis. 2, if you're planning to give them steroids for the joint, you have to know if their sugar is controlled. It shows you're thinking ahead to management.
Right. Okay, now the lifestyle and context cluster, FOSS.
F is family history. It's huge in rheumatology. Psoriasis, gout, RA, SLE, all have strong genetic links. O is occupational. Does he lay tiles all day? That explains the NEOA.
And the double S, social and sexual. Social is smoking and alcohol.
And smoking is a massive risk factor for developing RA. Alcohol is the classic trigger for gout.
And sexual history. That's a question candidates might feel shy about asking in a knee pain case.
It feels intrusive until you miss the diagnosis of reactive arthritis caused by chlamydia or gonococcal arthritis. If you don't ask, you don't know. Asking shows you understand the connections.
That makes sense. Okay, finally, the external factors, T, V, F.
T for travel Lyme disease, chikungunya, V for vaccination history, and F just circles back to functional history and quality of life.
So PAM, HUG, FOSS, TVF. If you group it, medical, screening, lifestyle, external history, it becomes a checklist. It stops that moment in the car ride home where you just scream, I forgot to ask about family history.
Exactly. It's insurance against your own nerves.
So let's bring it all together. You start with pain. You check for inflammation to confirm it's arthritis. You count the joints, mono, oligo, poly. You check the distribution, DIPs versus MCPs.
Then you differentiate the nature. Is it inflammatory long morning stiffness, better with movement? Or degenerative short stiffness, worse with movement?
You scan the body for clues, rashes, eyes, ulcers, check the red flags. And then you wrap it all in that PAM, HUG, FOSS, TVF safety net.
That is the long case algorithm. If you follow that flow, you're not just guessing. You're building a case. You're demonstrating clinical reasoning.
Which is what the examiners want to see. They don't just want the right answer. They want to see your work.
They want to know you're safe, logical, and thorough.
One final thought before we wrap up. We mentioned that migratory pattern inflammation moving from joint to joint. It really is a biological mystery, isn't it? Why does the body attack the left knee, then just get bored and move to the right elbow?
It is. It reminds us that for all our checklists and mnemonics, the immune system is incredibly complex, sometimes unpredictable. The framework helps us navigate the chaos, but the biology underneath is still full of wonder.
A little humility for the road. Thank you so much for breaking this down. For everyone listening, good luck with your prep. Master the definitions, count the joints, and don't forget the morning stiffness.
Stay systematic, stay curious.
We'll see you on the next deep dive.